All right, let's jump right in. In this explainer, we're going to sharpen up our diagnostic toolkit. We'll break down the absolutely essential clinical tests you need to know to confidently figure out what's causing that shoulder pain. Okay, so you've got a patient in front of you complaining of shoulder pain. Where do you even start? Right, the key here is a really structured physical exam. You want to organize your whole approach around the most likely culprits. So we're going to systematically test for the common pathologies, and we'll kick things off with impingement. All right, first up, let's tackle what's probably the most common piece of this whole shoulder pain puzzle, impingement. We're really going to zero in on the supraspinatus tendon, mainly because it getting compressed in that subacromial space, well, that's one of the most frequent causes we see in the clinic. So our first big clue is the classic painful arc sign. What you're looking for is this. As the patient raises their arm out to the side, do they feel pain specifically in that window between 60 and 120 degrees? If they do, that's a really strong suggestion that the greater tuberosity is squishing the supraspinatus tendon up against the acromion, and you'll often notice the pain kind of fades away once the arm gets past that arc. Okay, next up is the Neer test. Now, this one is what we call a provocative maneuver. What we're doing is passively forcing the arm into forward flexion while it's fully pronated or internally rotated. Basically, we're mechanically jamming the greater tuberosity right into the front part of the acromion. If that supraspinatus tendon or the bursa is inflamed, this is going to light it up. And it's exactly because of those mechanics that the Neer test is considered the most sensitive clinical test we have for supraspinatus issues. So if you get a positive Neer test, your suspicion for impingement should shoot way up. But here's a key clinical pearl. Remember, it's highly sensitive, which is great for ruling out impingement if it's negative, but it's not super specific, so you're going to need other tests to really lock in the diagnosis. Now, to really hone in on the supraspinatus, we've got the Jobé test, or as you probably know it, the empty can test. You have the patient hold their arms out as if they're emptying a can, thumbs pointing down, and then you have them resist you pushing down. What's crucial here is that we're not just looking for pain, we're also checking for weakness. Weakness could point you towards an actual tear, not just inflammation. And rounding out our impingement tests is the Hawkins-Kennedy test. Just like the Neer test, the whole point here is to mechanically narrow that subacromial space. So you'll flex the shoulder and elbow to 90 degrees, and then you internally rotate the arm. What this does is it drives a supraspinatus tendon right up against the coracoacromial ligament. If there's impingement, that's going to be painful. Okay, so impingement is a huge piece of the puzzle, for sure, but it's definitely not the whole story. Now we need to zoom out a bit and broaden our assessment beyond just the supraspinatus. We've got to look at the other key players in the rotator cuff, the infraspinatus, the teres minor, and the subscapularis. And sometimes a really quick functional screen can tell you a ton. Think about it. The hand behind head motion, that's testing your external rotators, right? So the infraspinatus and teres minor. Then the hand behind back motion does the opposite. It tests internal rotation. This gives us a really quick clue about the subscapularis. If a patient can't do these simple movements, that's a huge red flag for rotator cuff problems. All right, let's get specific. How do we isolate the subscapularis, that powerhouse internal rotator? For that, we use the lift-off test. You'll ask the patient to put the back of their hand on their lower back and then try to lift it away from their back while you provide some resistance. If they're weak, or if they just can't do it at all, that is a very strong indicator of a subscapularis tear or dysfunction. And honestly, this is a diagnosis that gets missed a lot. So, up to now, we've been focused on the dynamic stabilizers, the rotator cuff muscles. But what about the joint's static stability? We absolutely have to figure out if instability in the glenohumeral joint itself is part of the problem. When it comes to instability, there are really two cornerstone tests we need to know. First, you've got the sulcus sign. Here, you're just applying a gentle downward pull on the arm. If you see a visible gap or notch appear just under the acromion, that's your sulcus sign. It's the classic hallmark of multidirectional instability. Then, on the other hand, you have the apprehension test. This checks for positional instability. As you carefully move the shoulder into position where it might dislocate, the key thing to look for is the patient's apprehension, that feeling that their shoulder is about to pop out. That's the positive test, not just pain. Okay, we've covered a lot of ground here: impingement, the rotator cuff, and instability. So now let's pull all of this together into a really practical, high-yield toolkit that you can actually use in the clinic. Yeah, just think of this as your clinical cheat sheet. You suspect supraspinatus impingement? Your first thought should be the super-sensitive Neer's test. Need a quick and dirty screen for the whole rotator cuff? Those hand behind head and hand behind back movements are perfect. Need to specifically target the subscapularis? The lift-off test is the one you want. And finally, for instability, you're going to use the sulcus sign to look for multidirectional instability and the apprehension test for positional instability. Simple as that. So, at the end of the day, having a systematic approach is everything. It's about moving from those broad functional screens down to the more specific, provocative tests. That's how you're going to efficiently narrow down your differential. And really, the biggest takeaway here is that it's not just about knowing how to do the tests, but knowing when and why to use each one to solve that clinical puzzle of shoulder pain.